Dear colleagues, welcome to this session sponsored generously by Abbott Vascular. This will be focused on complete revascularization from defining PCI strategy to PCI optimization. Obviously, the session will be focused on physiological assessment of the lesion, then anatomical evaluation of the lesion by imaging, and finally we have a case presentation. Unfortunately, two of the presenters could not come to the session due to COVID restrictions for travel in their respective countries. The first presenter is very famous to this audience, Javier Escaned from Spain, who will be joining us by a taped video recording of his session on physiological lesion assessment. However, Javier will be available online to address questions. Prior to that, I would like to to have missed introducing my co-chair, Jean Fajadet, and my friends and fellows, the panelists, Dr. Sundus from Saudi Arabia, Dr. Mohammed Al-Kurdri from Saudi Arabia, Dr. Ziad Ghazal, Dr. Hussam Noor, and Dr. Khalid Al-Mirri, all of whom have extensive experience in coronary interventions and optimization of PCI by physiology and by imaging. I don't know if we have available the presentation by Javier Escaned. We can start.
Hi, it's a great pleasure to be with you in GulfPCR 2021 sharing with you some views on coronary physiology. The topic of my presentation is the use of contemporary coronary tools for full physiological assessment. And these are my conflicts of interest. We are going to review several topics on this very interesting aspect of full assessment of the coronary circulation, and we will also revisit some recent clinical trials that have implications in understanding the validity of recommendations in clinical practice guidelines. Let's first start about the importance of physiology in PCI planning. And for that, in the context of the recently published ischemia trial, let me just share with you these very important results of the DEFER trial, which at 15 years follow-up demonstrated that avoiding unneeded interventions is important because by having PCI deferral when it is not needed, you have a much lower rate of myocardial infarction in the long term, which is of course related to unneeded interventions. The safety of PCI deferral based on physiology has been recently reassessed in the current practice by pulling results from two large randomized clinical trials, the DEFINE FLAIR and IFR with heart analysis. And this gives us also the value of not only of knowing that deferral of revascularization of FFR is safe, but also to see that non-hyperemic pressure ratios like IFR or RFR are equally safe in making the decision of not performing stenting in lesions that are non-flow limiting. This is an example of how in clinical practice we assessed this patient with a long pattern of disease in the left anterior descending, and based on the pullback pressure with RFR, performed stenting, reassessed the result at the end, and ensured that we had achieved a good functional result of the PCI. Apart from trials, we have now large registries obtained in real life that demonstrate that adherence to the information provided by FFR in revascularization results in much better patient outcomes. This is one of such studies in the Ontario region in Canada, where you can see clearly how the patients who have much better result were those, again, emphasizing what we discussed before, that had non-significant FFR, and that this was followed by not performing PCI. On the contrary, you have patients in whom FFR indicated that there was a flow-limiting stenosis, but for whatever reason, the PCI was not performed. And these patients, of course, had higher event rate in the long term. But remember that physiology is important not only to guide PCI, but also to understand what are the causes of ischemia. And you can see in this study, that is a classic study from Manesh Patel, that in nearly 400,000 patients studied in the US with coronary angiography, even those who have positive ischemia tests and angina, the yield of the diagnostic yield of angiography was very low. More than 45% of these patients presented no obstructive disease, meaning that the ischemia had a non-obstructive origin. And it is very important to understand that, because while we have tools to assess stenosis, conductance in the epicardial vessels, FFR, non-hyperemic ratios, as we discussed before, we also have tools that look to the regulation of blood supply provided by the microcirculation, with tests that include coronary flow reserve, microvascular resistance, and acetylcholine testing. And these indexes can be obtained with the same tool that you use to assess epicardial stenosis. A very simple way to use, very similar, is this is the pressure wire X, that, as you can see here, is, I'm bringing it down the LAD of this patient as part of the diagnostic study. Thermodilution is performed by injecting saline boluses, like you can see here, at baseline and during hyperemia. And by looking at the difference in the mean transit time, the Coroventis system automatically calculates coronary flow reserve, which in this case is abnormal, 1.6 is below the cutoff of 2 for coronary flow reserve, and also resistance, which in this particular case is also high. So we know that this patient has a structural problem in the coronary microcirculation. Why is this important? Because the studies like the Coromaica studies and others have emphasized that only if you integrate this information in your decision making, you will improve quality of life and help in controlling angina. You have to start, of course, by modifying or suggesting the modification of lifestyle factors and also cardiovascular risk factors. But after that, the information that you have taken, for example, in this particular patient who has microvascular angina caused by microvascular remodeling, is that you should try to start first with a beta blocker. Completely different thing than if the test would have been normal in this regard, but you will have demonstrated that there was a vasomotor disorder with acetylcholine testing, in which case you should use a calcium channel blocker. So this is the principle of stratified medical treatment in patients with INOCA. And finally, what is the impact of the FAME3, FLOWER-MI, and future trials, all of them using FFR in one way or the other, but showing negative results on the guidelines recommendations to use physiology? First, remember that the 2019 guidelines on myocardial vascularization were saying that you can use FFR or non-hyperemic pressure ratios to assess the hemodynamic relevance of intermediate grade stenosis. And at that time, the guideline says when evidence of ischemia is not available. All this was obtained mainly in the setting of chronic coronary syndromes. Subsequently, the guidelines on chronic coronary syndromes expanded the use of pressure guide wires also to situations where you have already documented ischemia. Why? Because, for example, even if you have non-invasive tests demonstrating ischemia and you have multivessel disease, it will be important to outline which stenosis of this pattern of multivessel disease is accounting for ischemia to avoid, again, unneeded interventions. And it may also be important to assess in situations where the patient does not have angina and does not have a proof of ischemia, to check that everything is correct in case that you have a major vessel, a vessel that is providing blood to a large surgery. You want to double check that there is no ischemia in a large myocardial territory. So with this in mind, let's move now to some of the recent trials. Phase 3, comparing CABG with FFR guided with, with PCI guided with FFR. The PCI did not demonstrate to be non-inferior to CABG. This is the main message of the study. You can see that the event rates were significantly lower in the CABG group than in the PCI arm in this study population of triple vessel disease. Now, does this in a way put any question mark on the use of FFR? Not at all. Because remember that the FAME3 trial, what is looking is basically a comparison between PCI and CABG. It's not looking to a comparison between PCI performed based on FFR or angiography, like it was the FAME trial. So in that particular aspect, the FAME trial, that was also a study performed in multivessel disease, demonstrated clearly that FFR-guided PCI is associated to better patient outcomes than angiographic-guided PCI. And that's the reason why this recommendation in the clinical practice guidelines about the use of FFR in multivessel disease, which is rooted in the FAME trial, remains untouched. Remember that the guidelines say that specifically the recommendation refers to patients with multivessel disease undergoing PCI. That means that they were already selected based, for example, on the recommendations on the use of syntax score for patients with multivessel PCI. Remember also that the populations of the FAME trial and the FAME3 trial were entirely different. In the FAME trial, only 23% of patients had triple vessel disease, while this was, of course, 100% in the FAME3 trial. I will not discuss much the future trial because this trial is fun to look at, but it simply does not have a statistical power. It was a study that was terminated early because there was a signal of higher mortality in the FFR that eventually proved to be a false signal. It's a very heterogeneous population, patients with multivessel disease or multilesion disease assigned to angiography or PCI or FFR-guided revascularization, very high percentage of ACS, patients with very recent ST elevation myocardial infarction, and on the top of that, a study where the adherence to the results of FFR was very low. As a matter of fact, 11% of cases with FFR that was suggesting non-ischemic lesions were treated irrespective of that. So I will not stop much because I think that this study is not important. And Flower MI is a study that basically looks to a comparison between complete revascularization in patients with STEMI and multivessel disease, either guided with FFR or guided with angiography. The study demonstrated that there was no superiority of FFR guidance in this particular subset of patients, and that probably has to do with the fact that the biology of non-culprit lesions in ACS may be potentially different to patients with stable coronary artery disease. But in any case, despite this is a very interesting debate about this study, it does not affect clinical practice guidelines because currently clinical practice guidelines do not make any recommendations on FFR in STEMI or non-STEMI. Finally, there are no changes in the recommendations made. None of these studies affecting the recommendations of clinical practice guidelines about using pressure guide wires to assess microvascular angina or to use acetylcholine for the same purpose. So I hope that with this presentation, I could have shared with you my thoughts that by identifying flow-limiting stenosis, as well as by outlining the focal or diffuse pattern of coronary artery disease, physiology contributes to better planning of PCI procedures. It's great that we have now the possibility of performing hyperemic and non-hyperemic measurements. It's great that we can also assess the coronary microcirculation. And it's great also to know that the evidence provided by recent studies that as part of the study design incorporated FFR do not modify the conclusions that led to recommendations in the clinical practice guidelines about the use of physiology in clinical practice. With this, I would like to thank you for your attention, and I really look forward to your comments.
Thanks to Khafir Escaned for his presentation. I guess Khafir will be with us for any further questions. We will have the questions after this next presentation of Jonathan Hill. If we have his presentation ready, his presentation is on imaging with OCT using artificial intelligence to evaluate and strategize for PCI optimization. Ready?
It's a great pleasure to be here as part of this symposium. I'm sorry that I can't be with you in person. I'm going to be talking about the role of imaging, and in particular, how OCT impacts decision-making. And we're going to be talking about the new tools enabled by artificial intelligence. These are my disclosures. So we're entering a new era within intravascular imaging, and in particular, the introduction of artificial intelligence, I believe, is the next evolution, or maybe even revolution, in how we're going to be approaching our interventional cases. We've made huge strides from the first images we saw from coronary angiography and then angioplasty, and the introduction of intravascular imaging over the last couple of decades has really seen the introduction of a level of precision that we've not been able to enjoy until relatively recently. And OCT in particular has enabled that highly precise measurement of lesions and highly precise measurement of vessels to guide our procedures more accurately and more efficiently. And the integration of artificial intelligence into the OCT workflow in a standardized way is something that has happened really in the last year. And we've seen the advent of the Ultron One software from Abbott Vascular. And really, this is heralding a new era in intravascular imaging and guiding PCI. And the way that the first iteration of this software has been developed has been to use the basis of angio-OCT co-registration and introduce some key parameters which are going to guide how we do our cases. So in particular, lesion morphology and our interest in calcium clearly this is a hot topic within intervention. Being able to detect calcium with maximum accuracy and to determine our calcium modification strategy is a key step forward. But the fundamental technology, which is AI guided within the Ultron platform, is the detection of the external elastic lamina. Now, we haven't yet seen the results of that randomized study, the Illumion 4 study, which I expect is going to show the value of measuring the external elastic lamina in achieving the maximum stent area. And using the co-registration with live angio has been done in a very elegant way, which enables you to use these AI-generated measurements where you're going to land your stent and integrate it with live angio. So the strategy and the optimization process are now part of this workflow that has been christened MLD Max. So this is essentially the pre-procedural phase is MLD, so measuring the morphology and the sizing, and in particular the length and diameter, M for morphology, L for length, D for diameter. And then the post-procedural imaging is the MAX component. And what that stands for, M is for medial dissection, A for apposition, and X for expansion. So morphology, sizing, and then review. So let's take a case example where this has come into its own, where the workflow has been absolutely sped up and has been made super efficient by these AI-derived measurements. So this is a patient with chest pain with anterior apical ischemia. The first shot that is done, measuring the LAD, we do the co-registration steps. This is it happening in real time. And this very first image that we're obtaining with this angiogram, we're looking to get a co-registered image to work out, have we covered the lesion? Is the study of sufficient quality? And with this very first image, the answer to that is yes. And once we've got a baseline image, we can then go through our first inspection. And so the M component, morphology, was simply just pressing the play button up here, and the workflow has changed. We're now proximal vessel here. So we're driving through the vessel. I'm looking at the position within the artery, and then as you see the marker within the artery getting to this segment where there's the significant disease, I'm making a judgment about the plaque characteristic. Is there calcium, or is there sufficient calcium to justify calcium modification? And this is really done within the first few seconds of the procedure, and this is playing in real time. So questions that we ask at this stage after your first inspection: do we need calcium modification? Well, in this case, we don't. There isn't a circumferential ring of calcium. There isn't a thick layer of calcium, and there is not a distribution of calcium along the length of the vessel, which would require either rotational atherectomy or intravascular lithotripsy. So no calcium modification required. So you go on to the next step, which is then to determine where you're going to land your stents. So you're already at this key part of the decision-making just with one shot of the LAD lesion. And so we're trying to find out whether or not we know we're going to land the stent somewhere in this region, and we're either going to put the proximal end of the stent within this segment here, but we haven't quite elucidated the detail of this segment. So we've got to work out, are there suitable landing zones proximally and distally? And the answer to that is yes. And so we then go down to refining the size of the stent. So we do that from the distal external elastic lamina measurement, and we're going to use those measurements. Here you can see this white line in the longitudinal view represents the AI-derived external elastic lamina. So we simply position our markers, and here I've got the markers. I'm going to be moving the edge of the distal edge of the stent in until I've got a satisfactory stent size. So yes, we can detect the landing zone. What's the size? Well, here we are. I'm just making some distal and proximal measurements. I've got an external elastic lamina distally of 3.02, so a 3 millimeter stent, and I'm going to put in a 38 millimeter stent to cover the first part of this lesion. So single stent won't completely cover things unless if there is a lesion in the ostial segment of the LAD. So we're going to make some more measurements. We may have to overlap within that proximal segment. Where should they overlap? Well, we can move, we've got the length here. So it's going to be in this point here. So how do you work out where the overlap should be? Well, you're going to be manipulating this distal marker, pulling that in. So there we are. We're going to get a few millimeters of overlap, and then you extend the proximal edge. So actually, when we get to the ostial segment of the LAD, you do actually see there is a significant lesion. So in fact, you're going to have to bring the stent back into the left main here. So when we're going to be implanting a stent within the left main, I think contrary to many people's opinions, I actually think that OCT is the ideal tool for measuring with a high degree of precision the external elastic lamina within the left main stem. So can you detect the EEL in the left main? Well, absolutely you can. And here we're looking at edge detection, but if you can see in this image at the bottom, you can see the white lines within the left main. This is the AI detected EEL within the left main stem. And certainly we've got evidence that there is here we are measuring the EEL. In fact, it's 5.05 in this segment. So we're going to need a pot balloon of at least 5 millimeters. So you can detect it with accuracy in the left main stem. So we've got the sizes of the stent 1, stent 2, and we're going to select our semi-compliant and NC balloons. So we've got a 5 millimeter NC balloon for the left main. And so we then have to work out what we're going to do with post-dilatation. We've got a 3.523 going in with the overlap, 5 millimeter pot balloon, and a 3.5 we'll use in the LAD. So once you have all those measurements, and this really takes a few minutes to get these done very quickly and accurately, you then have to execute the plan. A 3x38 overlap approximately with a 3.5 by 23, post-dilated with a 5 millimeter balloon within the left main stem. You can see the optimization here with a post-dilated with a 3.5 in the LAD, and then you've got to check your work. So we're moving on to the MAPS component of the algorithm. We're reviewing the stents here. This is our initial inspection. Do we have evidence of dissection? So medial dissection, we've checked distally and proximally, there is nothing. Is there apposition and expansion? Do we have angiographic concerns? Absolutely not. And do we have then concerns about the actual stent deployment causing a dissection or a lack of apposition in the left main stem? Well, in fact, it's fully opposed within the left main stem. We've chosen our balloon sizes carefully, and so no dissection and good apposition. Looking at expansion, we've got 100% expansion, a highly satisfactory result, delivered extremely efficiently and very quickly using this standardized workflow. So we've got full expansion. What is the MSA? And so M8.31 within this proximal stented segment, highly satisfactory and a very satisfactory stented result. So in summary, this case, it shows that the left main stem and the LAD can be stented using artificial intelligence guided measurements. You can use AI to detect EEL and calcium, and it can guide your stent and balloon choice. And it enables you to go through the review process, the MAPS component of the algorithm, with a very high degree of efficiency and accuracy. So to conclude, artificial intelligence-derived measurements can be integrated into an OCT standardized workflow. Decision-making will be impacted pre and post PCI, and AI tools will offer better lesion insights, reduce ambiguity, and increase the precision of the PCI procedure.
Thanks for Jonathan Hill. He will be remaining with us for questions after the presentation of Dr. Arif Al-Nooryani, who's going to showcase a case that has been done with utilization of functional evaluation and imaging evaluation. Arif?
Good afternoon, everyone. Thank you very much for inviting me today. Actually, I'll be presenting 3 cases and the role of imaging and physiology in daily practice. And this is something that's happening every day in our clinic, and we are facing this challenge on daily basis more and more. The first case I'll present is a 75-year-old lady. She's a relative of mine, by the way. She's hypertensive, diabetic, and dyslipidemic. And she came complaining with chest pain on exertion for the past 2-3 weeks. Her ECG did not show much significant changes. 2D echo also was showing normal systolic ejection fraction and no resting regional wall motion abnormalities. Labs were normal, negative cardiac enzymes, and she was already on aspirin, a statin, and Coverzeal or perindopril. So this was the right coronary, which shows mild to moderate disease in the mid segment. So that was certainly not significant. And then we have here some kind of the left coronary at the distal left main, if you appreciate, there is a kind of haziness, a bit ambiguous here. We cannot differentiate exactly what's there, but here maybe we can see some kind of eccentric plaque, and around 50%, I would say, distal left main. But we were not still sure about what is there. Anatomically was a bit difficult again in this view. So this is one of the challenges that we see sometimes, angiographic limitations sometimes. Here we can see again some whitish spot in the distal left main here. So I don't know how many of us would treat this case with a normal ECG, negative cardiac enzymes, normal echo. So what to do in this case? So this is really a question that you may come up, and you will be lucky if you have an OCT or imaging tool, other like IVUS or FFR, physiology, which one you will choose. We do an FFR, physiologic assessment, and then it's 0.89. So now, again, what to do? I would leave it. If you leave it, nobody will blame you. I mean, you have negative FFR, you have angiographically nothing there to discuss about. So I believe maybe 50% of us would leave it. I thought, no, patient had clinical symptoms. That's what counts. And she's really a decent lady, and she wouldn't say it some way without having a genuine reason. Decided to go for OCT. So OCT shows, if we have co-registration, you can appreciate the co-registration. We're coming from the proximal LAD, and then you will come to the segment where you will start seeing a plaque. So we'll appreciate there is a fibroatheroma at the distal LAD, and almost a ruptured one. We'll play it again and try to stop that. You can see it in the longitudinal image that there is some kind of weak attenuation of the plaque, which is indicating for a fibroatheroma, necrotic with thin. It doesn't stop, I don't know why. So it showed, I'll play it again if you wish to, but that showed this kind of fibroatheroma with a ruptured plaque there. So that is the discontinuation we can see of the intima there at 9 o'clock. So that is somehow looks like a ruptured plaque with fibroatheroma. This is a lipid-rich plaque. We don't see calcium much here. We don't see fibrosis, but we can see the necrotic valve with a thin cap. So this lady certainly had a reason for her symptoms, so we decided to go with the 3/5/18 stent and into the left main. And that is the final shot after potting. That was the final shot. This is the spider view. This lady came back to me after week or two, and she said she's free of her chest pain. She had no more chest pain. So this was really a good case to demonstrate how come things might change through the OCT or imaging. This is case number 2, a 65 years old lady, diabetic, obese, presented with non-STEMI, complicated by complete heart block, and then ECG showed this time ST depression with inverted T in the anterior leads, echo as showing fair systolic LV function, and then labs were normal almost. Home medication, she was already on statin, aspirin, oral hypoglycemic agents. The right coronary was okay. And then we will see the left. This is a good right. This is the left system. We have an intermediate lesion in the mid portion, and the proximal, there is another lesion here, which has not been estimated well here. In this lesion, we can see again, there is a lesion here and another lesion proximally. That is not much significant, frankly said. So RFR, 0.78. I don't know how many would do nowadays. It's quite frequent that we do IFR, RFR, non-hyperemic testing. And this was the OCT. It didn't show much distally, but there was some kind of stenosis here. And then we come to the proximal part, which is more significant. we can see the co-registration up here. This is the lesion where there's a thin cap. We can see that quite fibroatheroma between 2 and 6 o'clock. And again, this was for us, in this situation, a negative positive RFR, I remind you, positive RFR, along with this thin cap together. That makes sense. In this case, we have placed a stent distally due to the MLA result and proximally due to the thin cap that we have appreciated in the previous OCT image. That was the final shot. Case number 3, it's a 45-year-old gentleman, ischemic heart disease, diabetic smoker. PCI to left main lady was done earlier, and RCA got 3 Magmaris in 2016. Presented with angina, class 2. ECG showed inverted teen inferior leads. We had really our initial experience with the Magmaris at that time, and we thought that could be the reason. And when we checked, the labs were normal, echo was normal almost. So we did the long-term result of left main was okay, ostial LCX okay, RCA showed some kind of moderate ISR. So this is the angiographic. Here we had 3 Magmaris overlapping from the proximal to the distal. So you would say this is really something that maybe the reason, the cause of his symptoms. So this was the LAD, as I said, nothing major. Looks fine. Left main stent looks fine. Again, from our projection, nothing there. So no other cause. So what we do, OCT, and it shows diffusely ISR. We see some humps there. That is common in the Magmaris. We see it frequently. This is now 5 years ago, yeah? So we have kind of lumen, narrowing. Certainly we lost some kind of MLA. But would you do this case? But it's a stable plaque. I mean, we could not see a thin cap here. We have seen, that's what we see typically in the golden tube in the time of the era of the absorb. But no thin cap. It is really a stable plaque we would consider. So was it really necessary to do this or not? We do an FFR, and we come 0.92. So again, this is now a different decision. But in this situation, due to the stable plaque, we didn't decide to do much here, and we thought the symptoms were really not very much strong to convince us to do something there. And by negative FFR, we have physiologic evidence. So we thought there is no much high risk at this in this patient. We optimized his medical therapy, and he came back in 4 weeks' time in the clinic, and he was asymptomatic. He was okay. So our take-home message that OCT helps to overcome limitations of angiography and thus optimize clinical outcomes, recognizing and treating relevant residual pathology, including vulnerable plaque. Guidance, optimization, improving PCI outcomes, certainly going to be very helpful through OCT. Thank you very much for your attention.
Thank you, Arif, for the nice presentation. Maybe I give the panel to Dr. Jean Fajadet to
first of all, we could discuss on the first part of the session, the physiology. You have any comments, Syed?
Yes.
On the presentation of Javier Escaned?
Well, actually, all the presentations today was superb. But here's the thing. We have plenty of data that was shown today that shows that physiology and imaging is very relevant prior to intervention and during intervention. But we also have plenty of data that shows that post-intervention, especially physiology, is very helpful. If you have a suboptimal IFR, FFR, worse results. But what we don't have, and correct me if I'm wrong, Jean, Brahim, whoever, that when we have a suboptimal result, we don't have randomized data that shows us that if we act on the suboptimal result, that we're better off or not. So today, 2 examples. This morning, your case, Arif, beautiful angiographic result, maybe a little suboptimal, 2.75 at the end. Who tells us that if we intervene, you left it, I would have left it, But how do we know that if we were to intervene based on those images, that the outcome is going to be better? Dr. Noor showed a case today where re-intervening on a suboptimal result, which angiographically looked very good, there was a perforation. So what we don't have is really a randomized data post-imaging intervention or post-physiology intervention that shows us what does our re-intervention do, correct? We don't have that.
Well, we have Khafir Escaned. Is he with us, Khafir?
Hi.
Hi, Khafir. Hi, Khafir. Thanks for staying with us. Well, nice to see you in Dubai, although not in person. So there was a question from Dr. Ziad Ghazal. Was a question, I don't know if you hear the question.
Yeah, I could hear it. So, it was a very important question, of course. And I think that absolutely, I mean, we have a lot of evidence for the time being about the importance of physiology to plan interventions, and particularly in chronic coronary syndromes. But as he nicely explained, we obviously are at the verge now of understanding how this modifies our results. Now, it's true that there are recently some studies that have been looking into this, randomized studies. One of them is the Target FFR trial that basically implemented a strategy to optimize the functional results based on FFR. And for the time being, the information we have from this trial is telling us that first, it is not that easy always to optimize your results just based on FFR, which in a way leads to a more important discussion that is perhaps in the future, what we will have to do is to predict or to simulate what is going to be the result of intervention before embarking into a stenting and then checking what was the result. You understand what I mean? If you have long stenosis, you have to know from the very beginning that perhaps your results with PCI are going to be modest, and you have to gauge if it will be important to move into that. And the second one is, for the time being, this study is reporting that the Seattle Angina questionnaire of those patients in whom PCI optimization was performed with based on FFR or not was not significantly different. So we have, his point is extremely important, and for the time being, obviously it makes lots of sense to understand and to check if you have obtained a very good result, but it certainly is true that we need good studies to validate the benefit for the patient.
Thank you, Ravi, and thank you again to stay connected with us. We have a comment from Tom Johnson in the room.
Just in response to Ziad's...
Can we have the microphone, please?
Just in response to Ziad's question about evidence regarding these cutoffs, and I agree there has to be caution about using a solitary number as our measure. So Ultimate IVUS is contemporary data with clinical outcome, out now to 3 years, and it's a Chinese study, but it did use a cutoff of 5 millimeters squared, an avoidance of landing a stent into a plaque burden of 50% and avoiding medial dissection. They were the 3 criteria, and it showed an absolute difference in terms of target lesion failure at the primary endpoint of 12 months, but again, out to 3 years, it's shown increasing effect. Now, in terms of OCT data, there isn't yet randomized data. Francesco Prati was the first to report with Clio PCI, and he's now just published in the last couple of weeks 7.5-year follow-up data, where intriguingly, actually, the one measure that continued to predict failure was an MSA of 4.5 millimeters squared. So I think there is a message that these numbers probably are important. I think they're very difficult to interpret in practice, and we need help in terms of the software guiding us in how we do that, with absolutely a balance in terms of patient safety, and not driving to get a number where you perforate or dissect or cause further injury. But it's learning.
Thank you, Tom. Himad?
Yeah, actually from physiology point of view, there is a study a few years ago looking at post-intervention FFR. And if you achieve FFR more than 0.92 post-intervention, you have a much better patent vessel on the long term. And so we have some data.
But the question is beyond this. There's plenty of data of what you mentioned.
Yes.
Low IFR post-intervention
is bad.
But when you intervene on that result, do we have data that tells you that you're better off? When you intervene
but that
on
particular
result?
study looked at 3 interventions to make the FFR better. It's not randomized, but at the end point, when you have a better FFR, you have a much better.
Time to randomize patients, Ziad, in your center.
And it's going to be difficult to randomize such patients. Yeah.
I have a question, and maybe the panel could discuss about that. To RF, your first case. I understand the case number 3. In other words, FFR, it's the 0.92. You do the OCT, stable plaque on this right coronary artery. You didn't do anything. My question is concerning the case number 1. So this case with this image on the left main, the distal left main, they did FFR, it's 0.89, so non-significant. And why not to stop at that point? Because if you do FFR, we will do nothing. You take the OCT probe, and you say that there is this lesion, eccentric plaque, could be rupture on the corner, and finally you treat it.
Okay. So, I answered the question already in the presentation. She's a relative of mine, first of all.
Not answer the questions.
No, but joke aside. No, actually, the angiographic image was not confirming. And this is a lady with a trifurcation, quite significant, healthy system. You wouldn't leave it that way. I mean, you have something, and she has presented with a clear, typical anginal pain on exertion that is worsening. And she was already on aspirin, and she was not getting better. And she was really coming and saying, I have a problem. And she went to a clinic somewhere, and they said, ECG is fine, echo is fine, go home. But she said, but I have something, that's why I came to you. So we thought we should give her all the kind of diagnostic modalities available. So why not to add an image and see? Because you know, I do believe in FFR, certainly. I mean, we have data, we have really solid data about that, but what about cases that they present like this? Do we have a chance of technical error sometimes? There might be technical error. There might be kind of, I don't know how to interpret that, but we hear about the drifts, we hear about this and that. Image is there. I mean, it's a simple additional information, very valuable information you may get. And in this case, it was, I think, maybe life-saving. So this lady could have landed with a cardiogenic, sudden heart attack or death somewhere on the road. So I think we should, the message from this case is, we should, first of all, believe our patients, think about the clinical presentation, all what we have, tools, items, everything's fine. But patient is in the focus of what we deal with. We should listen to our patients. That's the message of this case. And then, as we have certainly not learned enough till now.
Okay, thank you, Aref. Khaled, you have a comment, and then Haytham.
Yeah, so the cases we have seen with Arif is the same as what we have seen in the Cath Lab initiative data, which is using MLD max protocol algorithm, change 80% of the decision of the operators. So basically OCT changed, mostly it will change your decision if you based your initial decision on angiography. The other thing is, yes, the technique is important in doing the FFR, IFR. If you don't do it right, you'll get, false information, and it will be, not the right decision. So techniques, it has to be done properly, like in the IFR. You have to clear the guide, you have to disengage, you have to do it properly to have a valid result.
Haytham?
Yeah, just to add to that point, when we do FFR, we have to remember that 18 to 20% of patients will not adequately vasodilate their microcirculation. So despite you doing the technique as required, a fifth of your patients may not adequately vasodilate, and your FFR will be falsely normal. So that's one thing to remember, and you may need to use another vasodilator like papaverine, which we don't have, but that's one point to remember.
I think it's very important to take into consideration the effect of age and diabetes, because increasing evidence is showing that with advancing age, more lesions that look significant have negative normal FFR. So I think it's important to take this into consideration. Age and diabetes are very important mitigating factors for ischemic FFR. And this is showing in multiple publications lately.
Thank you. Hussam has a question. Then I think the first case that Arif showed is a very controversial case. I understand she is your relative, and when you have a relative, you either overprotect her or underprotect her. So I think you were overprotective. But we take Hussam's, and then we come to all the panelists to see what they would do in the first case of Hussam. I think it's important. Don't you think so? First, Arif had done his case, so we're not going to ask him.
No, I have a general comment. I mean, we, in coronary revascularization, it's in general I'm talking about, we come as a pendulum up and down and up and down. We started with courage, we started with a $100 million trial of ischemia, and then we have imaging, then we have physiology, and then really, what are we looking for? I think everybody, and certainly myself in the audience, is I want to know which and how any of these things have changed my practice. I have to ask myself, has any of these things have changed my practice? If you spend $100 million to make an ischemia trial, has ischemia really changed everybody's practice or not? So we're coming back to the basics. Physiology, FFR, RFR. So that, okay, fine. I use the physiology to assess the significance of the lesion if I want to do it or I don't want to do it. Then I have an issue. Sometimes I have them both in my lab, and I'm confused. The RFR is significant, the FFR is not significant. About 30% of the time you have this, the discrepancy. And how do you make that? Which one are you going to use? Are you going to use RFR, or are you going to use FFR? And what are the outcomes? I think there was a paper, maybe Javier would allude to that in a little bit, in Portugal, talking about that. Then we come into imaging. I have IVIS, I have OCT. Shall I use one of these imaging to decide to intervene or not? And I think in majority of the cases, I wouldn't use that. I would use those imaging modalities to optimize my outcome. Then we go to the INOCA. This is the coronary physiology, Coroventus. Okay, if you look at that algorithm that we've been shown, as Arif and everybody else he says here, I would believe the symptoms of my patient. Not uncommonly, middle-aged woman would come with chest pain. You do your usual treadmill test. The treadmill test is positive. You take them to the cath lab. I call them shut-up caths. You do the cath lab is negative, no significant stenosis. You send them home. They come back to you with angina. These are the people who have microvascular disease. These are the people you would then have to go. Do you really have to go back to the cath lab, do an invasive procedure to document that they have microvascular disease or not? Whereas it's pretty simple. You can put them on a beta blocker, calcium channel blocker, and give them a trial. You're treating them for symptoms. So that's my algorithm, simple algorithm of thinking.
Thank you very much, Hussam. I think we're running very short of time. Maybe the question of the first case, because it's important. It's an important case that Arif showed. It's a decision he made. Thin cap, possibly ruptured. Would you stent it or no? Say yes or no. Sundus.
No, I would go with more aggressive risk factor modification, because I don't think a surgeon will put a limo in this case. So that's why I go. Usually to revascularize or not, always
even if she's your relative.
Even if that's a more reason for it.
Ahmed?
Tough call. I would say Arif is the one who can make the decision because he's the physician looking after the patient. But looking at the fact that we've seen, I think this is why I think we will not be replaced by computers. Physician has to make the decision at the end of the day, and he acted as a physician rather than just a technician. And I think I would value that as well.
I would say no, but even symptoms can fool you. Even when you have symptoms and they go away, they may not be the same. I like to know the symptoms during balloon inflation. And many a times they're not the same as the symptoms that brought the patient to us.
one comment.
But she's your relative.
By the way, we do that routinely, Zia. We do that routinely. We ask the patient when we inflate the culprit, do you have the same pain that the characteristic of the pain? That was the routine what we do, and that was there.
Assam?
I make them all sleep, so I don't know about the symptoms, but I don't.
You don't? Khalid?
I wouldn't see any bad dissection, maybe some small dissection. I would leave it, especially it's in the left main.
Excuse me, I'm not going to say anything. John, you're not going to say anything?
No, personally, on this image, I will not use FFR.
You will not use the...
No, and I will go certainly for imaging. And so if I have the image, maybe I will stand it.
Yes. So, John, you maybe close the session?
No, first of all, thank you. I would like to thank all of you for this really interesting session. Thanks to Abbott to support this great symposium. Thanks to Javier Escaned, and I think that it's not the end of the story, and we will have the opportunity to meet again to talk about physiology and intravascular imaging, because we learn year after year in the details, and certainly the decision we have taken a few years ago will be for a particular patient will be totally different today and could be again different in the next years. So thank you for all the speakers, thank you for Abbott, and I think we move to immediately to the next symposium organized by Edwards. Thank you.
Thank you very much.